Hello, good evening. Welcome back to my IVF&x and the European Fertility Society. We are back once again, and today we will talk about a very difficult, interesting, and intriguing topic for sure. We will talk about mosaic embryos, and we have a perfect expert to discuss that for sure. Dr. Victoria Walker is with us already from Institut Marquès. So I'm really happy to have you here. We already established that we had a webinar together. It was a while ago, so I'm really happy that you are back and
Thank
you
you.
are going to present this topic. How are you, Dr. Victoria? Welcome to my IVF&x. It's great to have you for sure.
Thank you. Thank you for inviting me back.
We are
fine. Looking forward to doing the
definitely
topic.
happy to have you here. I know it's been a busy few days as you also attended 𝐟𝐨𝐫𝐞 in Paris. So I'm really happy that you are back and are ready to educate us a little bit on this particular topic.
Yeah.
And let me remind everyone that we will start with a presentation on the topic, but afterwards we will have a chance, you will have a chance to ask your questions. So please remember to put those in the chat. Dr. Walker will definitely answer them for you right after her presentation. And as always, let me remind everyone that this is anonymous, it's all recorded and will be available on my IVF&x website tomorrow. And of course, we are simply here to discuss this topic and hear from you, and also try our best to answer any of your questions. You can type the questions during the presentation or afterwards, and we'll be definitely happy to hear from you. I think that we are all set. Let us know if you can hear us. I hope that you do. I think so, but of course, please confirm for us that you can hear us. And I think we can go ahead with our presentation. So please let me know if you can see it, and I think we can go ahead.
All right. So thank you very much to everyone who's joined us this evening. We're going to talk about mosaicism and embryo implantation. And the question is, do mosaic embryos really have a chance? Okay, get there. So I'm Victoria Walker. I'm one of the doctors at the Institut Marquès in Barcelona. I trained in the UK and then moved out to Spain in 2005. And I'm very delighted to be here tonight. Institut Marquès is a clinic in Barcelona. It's been around for about 100 years, and I've been with them for about 20. So it's a good clinic. I'm very glad to work for them. So my plan for this evening is to try and obviously talk about mosaicism, but just run through initially on how embryos are formed, how we go about biopsying them in the laboratory, the form that the results can take, and how and why sometimes they come up with the result of mosaic. And then we can talk about, the implications of mosaicism maybe towards the end. And I will have time for questions for you, and I'll try and answer them. It's not a simple subject, and it's a subject that's changing all the time. So hopefully I'll give you the most up-to-date information about them, but it may be different again tomorrow when something else is published, but I'll do my best. So with a very simple thing to start with, this is we begin with an embryo. So if you look at this image in the top left-hand, on the top left-hand side, you've got an egg. And you've got a sperm that just is coming up to the egg. You can see it's touching the edge of the egg. And when it touches, that first sperm touches the edge of the egg, the head goes through, the tail is left behind, and the gate's shut, as it were. So no more heads can get in. The head then comes towards the nucleus of the egg. You can see in the next image, and hopefully they fertilize. And then they start to divide. And that means that the embryo has fertilized. And you can see that the cells start to go from two cells here up to 4 cells. That's on day 2 of their life. And then they go to 8 cells. That's on day 3. And then they go to what looks a bit like a blackberry. And in Spanish, if it helps you, that's a mora. A blackberry is a mora. And this is the morula stage. So it looks like a blackberry. And then as it moves towards the end of day 4 and towards day 5, the cells start to spread out, and you get a layer of cells around the edge of the embryo. And that's what we call the trophoblast or the trophoectoderm. And then here you can see a blob of cells, and that's the inner cell mass. And this is what an embryo should look like on day 5. And this is the inner cell mass is what will correspond in the future to the embryo, and the trophoblast or the trophoectoderm is the part that will hopefully become the placenta. So this is the first 5 days of life, and you can see that it all takes place within the shell of the egg. And as the embryo gets to day 5, it starts to break out of the shell of the egg, and you hope will move towards implantation. So how can we tell if an embryo is good quality or not? Well, of course, you can look at it under the microscope, and we've got lots of different types of microscope. What are you looking for under the microscope? Well, you want to know how many cells there are. Are there 2? Are there 4? But are they well distributed? Are they symmetrically distributed over the embryo? Or are there lots of fragments? Because you don't really want to have fragments. Nowadays, with big data and AI and the help of AI, there are more and more ways of assessing an embryo that don't involve testing them, not actually directly invasively testing them. But for now, none of those tests are routinely done in the laboratory. For us, the main way of testing an embryo to see if it's of good quality, apart from looking at it under the microscope and seeing if it's symmetrical and all the rest of it, is to do pre-implantation genetic testing. So PGT, and we're going to be talking today about PGT-A because there are other types of PGT-A that are not really relevant for us today. So how is PGT done? On the left here, you've got an image of the embryo under the electron microscope. This is, and then you can see the same image that's been colored. So again, we've got the outer part, the outer thin layer of cells, which is the trophoectoderm, the bit that will become, we hope, the placenta, and that's the blue part. And then in the center, you've got the inner cell mass that will become, we hope, the embryo, and then you've got a space in between, which they call the blastocele. So what happens is on day in our lab most of the time, on day 3 of embryo life, they start to make a few tiny holes with a laser on the outside of this trophoectoderm, so that over the following 48 hours, so between day 3 and day 5, the trophoectoderm, not the inner cell mass, but the trophoectoderm just starts to sort of feed through some of the holes, some of its cells. So sort of shows it a little bit here. And the cells just sort of come out, and the embryologist can flick them off or pull them off. And they usually take between 4 and 10 cells for each blastocyst, so each day 5 embryo of good quality. And that sample is then obviously put into a tube here. 4 to 10 cells are not enough for us to really analyze. So they then grow the cells. They put them into culture so that they multiply, and they send that sample off for analysis, which in our lab takes about 2 to 3 weeks to come back. And the result will tell you whether your embryo is normal or not. And that's what we want to know. So what are the results you can get from PGT? So you can get, well, 3 main results, but you can actually get 4 most of the time. So you can get the result that your embryo is euploid. that means the embryo is completely normal. All the cells tested, the 4 to 10 cells that were taken, were normal. And you obviously want to keep that embryo. Then you've got that the embryo might be aneuploid. That means all the cells are abnormal. And in that case, we usually throw the embryo away. Or you can get a different result, which shows that some of these cells taken were normal and some were abnormal. That's a mosaic. And the fourth result that you can have is that it's non-informative, in which case you have to try and rebiopsy the embryo to go and get a full result, or a second result for that embryo. So today we're particularly interested in this last group of embryos, the mosaic embryos. And here you've got an image. You can see that the blob, the inner cell mass, is made up of different colors. So blue and red colors. So let's imagine blue and normal ones are genetically normal cells, and the red ones are genetically abnormal. And you can see that if you're taking a biopsy of the outside, the trophoectoderm, or the trophoblast, then it depends on where you take it, really, what you might consider the result to be. So if in this top image we take 3 blue cells and 2 red ones, you might say it's a 40% mosaic. So it's got 2 of the 5 are abnormal. But if you've taken your biopsy a little bit higher and you've got 5 out of 5 normal ones, you might say the embryo is not euploid, completely normal. Or if you took your biopsy somewhere else, you might find that all the cells are abnormal. So you've got to sort of know what your lab does and how they work and how reliable the results are in your lab and how good your colleagues are at doing all these biopsies. And they standardize and they do lots and lots of tests to make sure that what they're getting, they're really sure represents what is happening in the inner cell mass, which is the bit that's going to be the embryo. We don't actually biopsy the embryo itself. We're interpreting the outer part that's going to become the placenta and thinking that it relates to what's going to be what will be the genetics for the embryo. So this is a bit of a complicated slide, but this is, hopefully I can explain it in a way that will help you to see what it means. But essentially the next generation sequencing is the technique that's used in the laboratory at the moment to understand the result that's come from the biopsy. So if we take the top image, if you look along the x-axis, which is the bottom one along, well, you can hardly see them, but there are numbers, there should be numbers on the x-axis. For a human embryo, there are 23 pairs, so there are 22 somatic cells, and there is an X and a Y. So along the x-axis, you'll be seeing normally 1, 2, 3, 4, 5, 6 up to 22, and then X and Y. And then on the Y-axis going up, you've got lots of little numbers that you can hardly read, but essentially you've got 3 horizontal lines. One comes at 1, another one comes at 2, and then another at the top, 3. And you can see that the wiggly line, the wiggly green line, is running along horizontally at 2. So what does that mean? That means that for this particular embryo, you've got 2 chromosome 1s, you've got 2 chromosome 2s, 2 chromosome 3s, and so on and so forth until 2 chromosome 22s. And in this case, you've got 2 chromosome X's. So this shows a result that confirms that this particular embryo has 46 chromosomes, which is what you want for a human, and 2 of them are X's. So this is a genetically normal female embryo. And then if you look at the second image, it's almost the same. So the wiggly green line is in the middle. It runs along at 2. So you've got 2 chromosome 1s, 2 chromosome 2s, 2 chromosome 3s, until you get to chromosome 9. And in chromosome 9, it's not there. It's gone up to the level for 3. So that means that for chromosome 9, there are 3 chromosomes instead of the normal 2. That means that the total for that embryo has gone up to 47, which is abnormal, and you've got a trisomy 9. So 3 chromosome 9s instead of the normal 2. So that's an abnormal, that's an aneuploid embryo. If instead of going up to the level of 3, it went down to the level of 1, then you would say it's lacking a chromosome. It's got a monosomy 9 instead of a trisomy 9. So it's only got 1 instead of the normal 2. And that would be abnormal as well. So knowing that, if we look at the bottom one, again, you can see there's 1 chromosome. The wiggly line is going along quite happily all the way along. Well, it's a bit irregular, but it's going quite happily along the line of 2. And then when you get to roughly chromosome 17, you can see it goes down, but it doesn't go all the way down to just 1. So that means that it's missing some of chromosome 17, or there's an abnormality with chromosome 17, but it's not a whole chromosome that's missing. It's just part of that chromosome. So that is a way of visualizing what they might see in the laboratory as a chromosome 17 mosaicism. And the laboratories, some of them are really, some of the laboratories will say that their results, only 2% of their embryos are mosaic generally. And other laboratories will say 6%. Most of them are quite low. But some laboratories will say that 40% of their embryos are generally mosaic. So it can be quite variable. Why is there a variation in this percentage? Well, it's probably, we're not sure why, but there are many possible reasons. It could be related to what we do as clinicians in terms of the ovarian stimulation, because all of these embryos have come from IVF. So is it something that we give the patient that makes them just have more mosaics and things like that? Or is it related to the laboratory, what they're doing in the laboratory? Is it the technique that they're using to fertilize the eggs? Is it the culture media that they have? Is it the operator, the actual person who's doing the biopsy? Does that person have an effect on things? Or is it maybe the NGS technique itself? Are they actually just, is it too sensitive? Does it pick up details that maybe is not relevant? It's too much information. We don't need to know that because, well, you'll see that the results are good with mosaic embryos. So is it to do with the biopsy? Is it to do with the number of cells analyzed? They know that if they only take 4 cells, the results are maybe not as reliable as if they take 10 or so. Is it the analysis of what they're doing that's changing things? Or maybe are we getting a mosaic result because we've taken cells from the egg itself, from the outside of the egg itself? Those, if you remember right back at the beginning, the egg looked like it had a kind of slightly furry outside. And those are the cumulus cells. And maybe you could have taken, they are cleaned off, but they could be taken into the biopsy by mistake. And so you're analyzing a bit of the embryo's chromosomes and maybe some of the mother's chromosomes. And then there's a possibility that we're analyzing and finding these mosaic embryos, but actually it's not a problem. Maybe I read in preparation for this presentation, I read that there was a paper, somebody was mentioning that maybe we all started as mosaics. And then if we actually implant as embryos and evolve, we just self-correct. So maybe it's just normal for embryos to be mosaic. So there can be a wide variety in the percentage because of techniques, but also maybe because we're better. Some clinics, some labs are better at picking them up than others, or maybe they're too good at picking them up, or maybe it's just a normal phenomenon. The variation is normal. So how can you categorize mosaics? Well, there are lots of different ways, essentially. I've put 3 here, but there are more. And so you can do it either according to the number of chromosomes that are affected. So if it was just chromosome 9 or just chromosome 16 or 17 or whatever, that could be classed as simple. And if you had 2 chromosomes affect, maybe 9 and 17, that would be a complex mosaic. And then if you had more than 4 abnormalities, you could class it as chaotic. Chaotic isn't a very positive word, but you could still class it as that if you wanted to. Other clinics might say, or other people who analyze these embryos might say, we'll go just with low or high percentages. So how many cells are affected? Is it under 40% or 40 to 50%? Or is it more than 50%, for example, and say low or high? And sorry, apologies. Or maybe you could look at how which of the chromosomes are affected, and whether it's all of the chromosome or just part of the chromosome that's affected. And as I say, there are more ways of categorizing them. But categorization is to try and help you know what to do with them, really. That's all. It's just naming things so that you can try and help a patient to decide what to do. So what kind of results can we expect? Now, there was a relatively recent, reassuringly, there was a recent publication that suggested that in total there have been nearly 3,000 published cases of mosaics being transferred, and of those, not even a handful of babies born with a mosaic abnormality. So if a baby is born following transfer of a mosaic embryo, generally the baby born will be completely normal in maybe 97, 98% of the cases. But the mosaic embryo itself has a lower chance of creating a live birth than an embryo that's a euploid, that's completely genetically normal. So that's what we know about mosaic embryos. They have a lower chance of implanting, a higher chance of miscarrying. But if the embryo is evolving and gets through to the live birth stage, then it's normally a genetically normal child that's born. And that's very reassuring to know. So to help us deal with these mosaic embryos and what to do with them, because I remember about 10 years ago, everyone was very, very stressed about mosaic embryos. We really just didn't know what to do with them. We were just worried about them on behalf of the patients and things like that. So there are some international societies that made some guidelines for us, different international societies. So there's the PGT-A, so that's the Preimplantation Genetic Diagnosis International Society. They were one of the first to create some guidelines to help us. There's the Virtual Academy of Genetics that created a position statement. And there's the American Society of Reproductive Medicine. We at Institut Marquès tend to work with 𝐟𝐨𝐫𝐫𝐸, so that's the European Society of Human Reproduction and Embryology. But all of them over the years have helped us to learn how to deal with mosaic embryos. So I think, sorry, just going ahead. So maybe we'll start here. So in the past, the advice, when you had a mosaic embryo, the guidelines varied according to the position statement and who provided them. But initially, right at the beginning, it would be, if you get a mosaic embryo, particularly if it involves chromosomes 13, 18, 21, and X, chromosome 14, sometimes 16 as well. These are ones that you will almost certainly never be able to use. And so if you get a mosaic with those abnormalities, then probably you should redo a new IVF cycle for this patient. You shouldn't use them. You should just put them to one side. So that was what we used to say. And then you'd have also, if you did think you were going to use them, you had to advise patients to have really, really extensive, if they fell pregnant, really extensive prenatal testing. So probably an amniocentesis, invasive stuff as well. But now, based on the more recent research, we feel that low-risk embryos can generally be used as long as patients understand that they have a slightly lower chance of success with them, but they can give a live birth, then we can use them. And so we do use them. Up to about 50% mosaicism, we'll use them, and we won't say to patients, do another IVF cycle. No, let's try these ones. And we won't say to them that they need prenatal testing either necessarily. I mean, anyone who's done PGT is generally advised to have all the prenatal non-invasive tests, so all the scans, and to make sure that their baby looks healthy and everything seems to be growing correctly. But we don't very often recommend invasive tests anymore. So the 𝐟𝐨𝐫, the current guidelines, which are from 2022 that we're still using now, are that we should use these embryos and should give them a chance. It can be a bit harder with mosaics that have maybe a lot of abnormalities. So let's say the percentage is high, or the multiple chromosomes are affected, or they're chromosomes that you think you might worry about a bit more, like chromosome 21 or something. But at the same time, once you've had if you have a conversation with the patient and explain all of this, and it takes time to explain all of this, and to understand all of it as well, then sometimes you can use them. So that's the current approach. I'm just jumping over that. But the societies who help guide us as to what we should do with these mosaic embryos all recommend genetic counselling, because you should have really counselling before you do PGT, so that somebody can explain to you the possible results that you might have. And then you need a follow-up after you've done PGT to go through the results of what you've received and the implications. Because if you've got lots of euploid embryos, so genetically normal embryos, then that's fine, everybody's happy. But if you've only, for example, got a mosaic embryo, that's it, that's what you have, and you really, really want to use it, and your clinic will want to use it as well, because we want you to have a pregnancy, a good, healthy pregnancy. But if you need to go through it, because you need to know, well, the counsellor needs to know, and maybe your doctor needs to know, how comfortable you are with uncertainty. Because mosaic embryos can definitely work out, as I've mentioned, but they can give you miscarriages, and you could potentially have a baby born that carries the same mosaic abnormality that was seen in the lab. So you've got to go through all of this and see, are you okay with this? Knowing that your baby will probably be fine based on the studies. It'll almost certainly be a genetically normal baby that's born, but it might not be. So you've got to go through this, and how are you going to feel during your pregnancy? If you're carrying a pregnancy with a mosaic, are you going to worry, or are you going to be okay? What kind of person are you? What kind of couple are you, if you're a couple? And what other support do you have? So it's all the societies, whichever one you look at, they all recommend genetic counselling. So usually from the doctor, but sometimes from a geneticist. All right. So that's, I think, the main things that I wanted to say about embryos that carry a mosaic genetic configuration. We definitely feel they do have a chance, and they shouldn't be systematically discarded or disregarded. You won't transfer them first, you'll transfer the euploid embryo first, but they could be used. And I've had babies born from my patients who started off with a mosaic. So from our perspective, I think they should be given a chance. That's just the bibliography. And thank you very much for your attention.
Brilliant. Thank you so much for your presentation, and thank you for walking us through all aspects. Of course, I'm sure there are more that we could discuss, but thank you so much for introduction. I think it's a very important topic to discuss. Here's the question that we've got from Peter. Does the clinic usually take photoblastocysts before freezing or only at implantation phase?
Well, it depends on the clinic, but at Institut Marquès, we have what we call an embryoscope, which is a time-lapse technique incubator. And actually the photographs, the incubator takes photographs of the embryos every half an hour. And so you get a little video of all of your embryos, and you can log on and try and watch them evolving. So as your embryos are being made, you can sometimes, you should be able to access those images. You can then get little videos of that, and you can also get photographs, I think, as well at the time of implantation. But usually it's a small video on the day of the implantation.
Yep, thank you. I do believe it was useful and good answer for you, I hope. Thank you so much. And let me have a look. Next question from Peter. So PGTA results, do you receive a detailed report shareable with the client couple?
Oh, yeah. So we get the result that comes to us from the lab. Right. They've translated it for us into usually either, I think we can only do English and French, but anyway, we get the result. And then if it's a very easy result, we can just email it to the patient. So if you've got lots of normal embryos, great, fantastic. But if it's all abnormal, then obviously you get a phone call to go through that. And if it's a kind of mixture, then you might get a phone call as well. But yes, it's all
just
shareable.
So you can discuss it.
Yeah, sent to the patient. They get a copy.
So they can definitely have a look, and then if needed, of course, then they will be able to discuss it. Yeah,
that's right.
Okay. Thank you for the clarification to this one as well. Okay, we have a next question from Michelle. We have a day 5-4BC embryo. Our clinic labeled as the complex low-level mosaic embryos.
I'm glad you knew what LL was. I didn't know what it was.
Low-level mosaic embryo, I think, 3 chromosomes in 30 cells. Genesis was positive about it, but the consultant was extremely negative. So what is the likelihood of a live birth here?
Difficult to say. It's a complex one because it's got 3 chromosomes. So that's a negative factor, but it's only affecting 30% of the cells, which is quite a low number. The embryo itself is of relatively good quality. It's got a C in it, but we sometimes will keep 4 BCs if the embryo seems almost to be good. The likelihood of a live birth is very difficult to tell you, but in my mind, I would give it a go. I don't know your age. I don't know. all the other results? Is it the only embryo you have? Is it? I wouldn't transfer this one first, but if it's the only one you have, I would definitely think about doing. But when you've got embryos like that, you know, even if it's 5 or 10% chance of having a live birth, it might be worth it if that's all you have.
This is the additional information that we just received.
41.
Yeah.
And that's if that's the only other embryo you've had. So you've had a euploid transferred and it hasn't implanted.
Yeah.
Well, check everything to do with your uterus, I would say. Make sure that there's nothing, you're not missing anything there. And, you know, you've maybe done tests to have a look at the inside of the uterus. Because if a euploid, it's not unusual for a euploid embryo, so a genetically normal embryo to implant, but it's you've got to make sure that the uterus is normal afterwards. So if you can make sure the uterus is normal in all the different tests that you could possibly do, I would give that embryo a go. I think I would give it a go.
Thank you so much. I'm just checking if Michelle has added. Yeah, Michelle added that the Euploid day 6, and they have done 7 cycles already, but only last 2 PGTA. The PGTA was done, and they've done lots of tests, hysteroscopy, and had a yeah. Let me just have a look if I. Full immune protocol as well was added. Yeah, so here is additional information.
I think it's you writing also that the clinic won't transfer aneuploids. Yeah, that's right. I mean, mosaics, people, the clinic decide, or the lab decides where the cutoff is, because there are some embryos that have very high levels of mosaicism, and they just categorize it as aneuploid. And it's the same with very low levels of mosaicism. They just say that they're euploid, they're normal. So you've got this bandwidth in the middle, and that's the hard bit. And each clinic might take a slightly different bandwidth. But I think, I mean, you've given it a really good go with 7 cycles. That's really hard work. And if you're getting to the end, psychologically, it's hard to leave an embryo behind if you think it might have a small chance of success. So I would say, yes, it may not have a very good chance of success, given that your euploid one didn't implant. But if you've checked the uterus, you've done everything else you can think of, and your doctors can think of, maybe try and use it, and then move forward with maybe other treatment options if you would consider them.
Yeah. Okay, sounds good. Thank you so much, Michelle, for sharing. I hope that was helpful. And Michelle has added amazing. Thank you, Dr. Walker. I appreciate it. Yeah, thank you so much indeed. Hope that was useful as well. All right, let's go ahead with the next question from Caitlin. And can you also discuss the possibility of PGTA being inaccurate due to small number of cells sampled? There is a study, she mentioned the study is re-examining of PGTA detected genetic pathology in compartments of human blastocysts, a series of 23 cases from 2024. This is the study she mentioned.
Thank you for looking that up. So yes, PGT can have an error rate. I think at our clinic in the consent form, I think it's between 2 and 5%. So there is always that possibility that it's not correct, but most of the time we think it is. And yes, I mean, why do they think most of the time it is? Because most of the studies that have been done on embryos, you know, embryos that haven't gone for transfer, they're abnormal, they'll biopsy them, and then they can do tests, slightly more invasive tests, and see whether the two correspond. Those are studies that have been done in the past. And so most of the time, I think it's felt that PGTA is good and is reliable, and in our clinic, we feel it's a very useful tool. It doesn't give you necessarily the results you want. It often tells you things you don't want to hear. But psychologically, that can be very helpful in the longer term to see. We're so used to seeing things today, you know, written down. You see a report, it's black on white. It tells you things and you believe it. And if you see black and white that your embryo carries these trisomies or whatever, it somehow seems easier to accept rather than having miscarriages and things like that when you don't know what's happening. So PGT, we feel to be very useful, even if it doesn't give the results that you want. And yes, there's an error rate, but if, for example, you fall pregnant with an embryo, you are recommended to complete all the non-invasive tests to make sure that the result that you got for your embryo is true for your baby as well, your developing baby.
Yeah.
So yes, but you need studies like the one that you mentioned to make sure we're doing it right and make sure everybody is aware that it doesn't always, maybe there is a
it's not
percentage.
100, yeah, 100%, right? Like, so we need to remember that, but of course, otherwise you would go transfer after transfer without knowing if it's not working. You would know, you would be looking for the, you know, reason what's going on, right?
That's right.
So thank you so much indeed for that. And Peter would like to know, let me show you this, an experience with a Promeda Biology Park in Czech Republic.
No, I'm afraid I don't know the clinic.
Thank you so much, of course.
Sorry.
It's all right, of course. I just wanted you to see that. Let me go for the next question that we got. Monosomy 9, 45%. So what is the chance? Short question from Marina.
That sounds to me like an aneuploid embryo, not necessarily. So it's a 45% mosaic of monosomy 9. Sorry, I hadn't understood correctly. Well, let me see. I've got a document here. The chromosome, this is a document we used to use in the past. Chromosome 9 is considered a low-risk chromosome, or used to be considered a low-risk chromosome. It's only one aneuploid, so it's a simple abnormality. It's a slightly higher percentage, but it's in that kind of middle bit where you don't quite know whether it's low or high. The chances of very difficult to know, give you accurate chances of success. But in my mind, because it's a low risk chromosome and it's affecting under 50% of the cells, I would say you could try it. Yeah, but I can't give you a chance of success. I really don't know what the chance of success will be.
No, hard to say for sure.
Well, I find it hard to say.
Of course. Okay. Thank you so much indeed for that. And can you have a euploid trophectoderm, but a mosaic embryo itself? Is that one of the reasons euploids can also miscarry?
Yes, you can. Actually, that was, if you remember in the presentation, I said there were these 3 methods of classification. There are others, and one of them is this thing where you can have like a euploid embryo and an abnormal trophectoderm on the biopsy, or the other way around. It's normal and this. So I don't know if it's one of the reasons that euploids can miscarry, but it might be. Yeah, absolutely. You can, but it's so, I mean, the more you dig into it, I find it, the more you get, more confused you get. You try to stick to the rules and you think, okay, I've got it. And then it slips away and you've lost it again. But yes, according to the classifications, you can have that.
Okay, thank you so much indeed again. What do you think about segmental embryo with 2 chromosomes involved.
Yeah, but this is getting harder and harder.
I'm afraid so.
So, let's go back again.
Mm.
Well, segmental ones may be better than whole chromosomes. 2 chromosomes are better than more than 2 or more than 3. So that's again probably a low. It depends on which chromosomes are affected, I think.
There's another additional information. Is considered high segmental as diagenomics flags, low segmental as euploid. What's the rate of live birth?
Live birth rate, it's very hard to give.
Yeah.
I mean, live birth rates when everything's normal probably are, a lot of the time, about 50% per try. So it's going to be somewhere under there. But if you treat a segmental as a euploid, as Mark suggests, yeah, it depends on the chromosomes maybe more than anything else. But you're probably, if you're, yeah, well, then it would be about a 30-40% chance of success.
Mark, thank you so much for your question. I hope that was useful.
I hope I'm not getting all confused, everyone confused now. I'm feeling slightly confused myself. But
not an easy topic indeed, and there's no like yes or no kind of answer for this, right? So it's not really easy. So I think that's it. If you have anything else, you know what to do. Thank you so much indeed. And there's another question here. We unfortunately lost our only euploid in 2nd trimester. I have a mosaic left. You can see the details. What to understand from this embryo mosaicism and success rate? Anything you can say?
I think you should see a geneticist. I don't think I've got enough knowledge to be able to accurately. That's exactly the kind of thing I would sort of cut and paste and put in an email to our geneticist and ask them to see the patient, because that is so you want to give a patient a really good chance of success. You don't want to give them another problem. That patient has already been through a really tough life event. So I would ask for advice on that one. I wouldn't know what to, for some of them you can say, yep, that's fine. But for one like that, I wouldn't know what to say.
It's more complicated. It's also better to just have that consultation with the geneticist just to give you the odds, of course, for this particular embryo.
Well, the odds and the risks and understanding the risks. And that's the hard bit. Yeah, I think it's the risk and understanding.
Makes sense. Thank you so much indeed for that. And next question, is it correct that PGT testing is cells taken from ectoderm rather than ICM rather than not through representation of growing embryo? Also, PGTA euploid embryos still can fail. I understand it could be other reasons like uterine issues affecting implantation, but makes me think, is PGT the way necessary if mosaics can self-correct?
Let's take this in parts.
Yes, definitely.
So, is it correct that PGT testing is taken from the trophectoderm rather than the ICM? Yeah. So it's an interpretative test, but at the same time, from research, they do feel most of the time that the biopsy that they take is representative of the inner cell mass. There are those mosaics where they're different, as I mentioned earlier, but most of the time in PGT, if you get a euploid result from research, they think that the embryo is also euploid. Euploid can still fail. Yep, they can be uterine issues affecting implantation, but it makes me think, is PGT the way necessarily? If mosaics, well, mosaics can self-correct, yes, but PGT, as I was saying, I think it gives information. I mean, obviously you want to have a euploid embryo, and if you get that, you feel confident using an embryo. It gives you confidence. And if it's all abnormal, everything is aneuploid, it gives you information, not information you want. And then the mosaics are somewhere in between. I mean, one specialist in Australia said to me, well, we just ignore mosaics because it's like when we didn't do PGT. So that's another position. You could say, well, I'm not going to do PGT because if I get mosaics, I'm still going to use them anyway. But I still think it gives a useful, if you get the euploid and the aneuploid, that's useful in itself. And the mosaics, well, you might well use them, but you know they don't have such a good chance of success.
Yeah, then you have the information, what is going on, I think, as well.
I think it's useful information.
Thank you so much, Belinda, for your question, to your help with that, Dr. Walker, and I think that was useful. And next question. So, have you encountered compassionate transfer, maybe for those with high-level mosaics and religious reasons, so they just want to start the embryos?
I haven't come across that. It's not something I've talked about with any, but we do. There are always cases, certain cases, particular cases, patients, for one reason or another, they're in their particular life circumstances, religious reasons or whatever. And so you can talk. In our case, we would just go to the directors and say, there's this patient, this is her situation, this is the reason, this is what she'd like to do. What do you think? And the directors will often take it to our meetings, the clinical meetings that we have together, and the decisions made. Can we help this patient to do what they want or not? And if it's not going to be, in any way detrimental to the woman herself, or we don't think it is, then often we'll be able to do things. So compassionate is what we hope we all are. We all try to be. But I haven't heard of the term a compassionate transfer, but you can understand why there might be reasons for thinking about transferring an embryo. At the same time, we won't, same as another patient, another commentator mentioned, we won't transfer aneuploid embryos. Yeah. So if an embryo has just been shown to be completely abnormal, it doesn't matter what people are saying, please, 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 we won't transfer them. We'll keep them. We can keep them. I've had patients who just don't want to throw them away.
Yeah, exactly. Yeah.
But we won't transfer them.
So that's clear. I think it's important to note that as well. Okay, thank you so much indeed. We have a mosaic complex chromosome abnormalities, 50%, over 50% awaiting genetic counseling, so unsure of details yet. Graded 3AB, should we consider transfer?
The 3AB is a lovely embryo. It's not very expanded, but it's a nice embryo. And if it's got complex abnormalities, that's usually between 2 and 4, because it might be, if it's more than 4, it might be chaotic. It depends maybe on which chromosomes are affected. That might make you go one way or another. But the percentage is under 50, which is a good thing. That's a lower percentage. So based on quality, you'd say yes. You'd use that embryo if it hadn't undergone PGT, probably. If you're just looking at the morphological quality under the microscope, you'd probably use it. And with the additional information, between 2 and 4 chromosomes and less than 50%, I think at our clinic we probably would advise the patient to try it. I think probably. Obviously, on the understanding that the embryo has a lower chance of implanting and a higher chance of miscarriage. But if it's your only embryo left, then in that case, I think we probably would.
Okay, thank you so much indeed. We will be slowly finishing, but I think there are like 3 questions left. I think we can still answer, right? So thanks a lot for those. It's not easy answers to those, but let's have a look at the next. So the lab that our clinic uses will not tell us the exact breakdown of what is considered mosaic and what is aneuploid. That line is key because the clinic won't transfer aneuploids. Do you have any advice on how we can get the information? What are the questions we can ask? Anything you can advise here?
that's a bit difficult because the clinic will have had a discussion with their lab about what cutoff they're going to have to say this is going to be classed as aneuploid and this is going to be classed as mosaic. But I don't know how would you speak? I mean, just explain you'd like more information. I can't think of anything clever to I mean, patients often want information. Sometimes the clinics don't have the information themselves, but a conversation they can have and they can say, well, we don't have this or we can't give this. I mean, for example, here in Spain, you know, sex selection is illegal as it is in most countries. So, you know, patients sometimes ask us for the information about their embryo, and the answer is just no. I mean, there's no discussion about it. It's not, well, we could go back to the directors and say, yes, ask this. But in this particular case, I think it's just a question of going to your particular doctor and explaining why you'd like the information, and is there anything the lab can give you to help you deal with your results, to understand your results better. Maybe ask to see a geneticist with the result, even if you can't see the result. Maybe ask to have an appointment with a geneticist, with your doctor at the same time, so that you can all have a better understanding of what you've actually got there, maybe.
Okay.
I'm not sure if
Thank you. Not an easy question again as well to answer for sure. Just you know, right now, of course. But thank you so much, and let's have a look. Okay. Next question again, not the easiest one. Okay, let me just show you from Peter once again. So previous cycles without PGTA, we barely got to blastocysts. This time we insisted on PGTA and suddenly had 7.
Wow.
Way many for testing. Yeah, other egg donor and stop smoking, etc. So hence extra cost for PGTA. So is PGTA for real or just another money scheme for the clinic? Sorry for the implied negative perception. Anything you can add?
Yeah. So this was a new egg donor.
Looks like it, yes.
And Peter, who's put his name down below, must have stopped smoking as well, which maybe affected his sperm and improved the quality of his sperm. So it could be, I don't think, I mean, PGTA makes money for the clinic, but at the same time, you can get very different results from 2 different donors. It can happen with the same sperm. So it's not necessarily the fact that you were doing PGTA this time around. It was just probably a new donor. Maybe the sperm got better if you stopped smoking and things, but it could just be that it's a different donor and a better cycle overall.
That's why the better result, yeah?
Yeah, I just to give you an example, I had a couple that came from Australia recently. The first donor, we got no embryos at all from the first donor. And we used the same sperm sample with a second donor. And I think we had 1 to transfer. This is blastocyst, 1 to transfer and 3 to freeze. Exactly the same sperm sample. But it was just a different cycle. Sometimes cycles can not go very well. And sometimes, luckily, they can go much better. So I would just be very grateful for those 7 lovely blastocysts.
Yeah, thank you so much for the clarification. I hope that was useful as well. And again, I think this is the same patient as before. So I'm 39, I have untested embryo from age 33, which is day 7 for BA. Also, I have another embryo from my last cycle, which is mosaic with details, as you can see here before. How do you explain this mosaicism? What are my chances with the mosaic embryo? Which one we should consider to transfer first, mosaic or untested one? A tough one for sure.
Yeah, I mean, age 33, embryos. I mean, I don't know, I obviously know nothing about your history and how long you've been trying at that stage, and you were obviously doing IVF, aged 33, so there was probably a problem somewhere that took you to the clinic that young. Whether it's a male factor or a female factor, it's difficult. I don't know. And this is a day 7 embryo, which is, well, 6 years ago, sorry, that was quite unusual to freeze embryos on day 7. So your embryologist must have been feeling pretty confident about that embryo. They only keep the ones that are really, really beautiful on day 7. But statistically, age 33, that type of embryo should still have a relatively good chance of success. Not as high as if it was a day 5 embryo and a 4BA, but it would still have a reasonable chance of success. So in my mind, I'd go for the one probably the one from when you were 33 first, and then see the geneticist and ask more about that deletion, because that's an embryo from when you were older, and it needs more of an assessment, I would say.
Definitely.
But I do think maybe I've given the wrong idea. I can't say necessarily with the mosaics the percentage chance of success. I think the purpose today was to see whether they should be transferred or not, or used or not. But the chances of success is a very difficult thing to discuss. And I hope I haven't misled anyone really in thinking that they should be used, they shouldn't be used, and things like that. But I don't think you can give accurate chances of success.
True. Okay. Thank you so much indeed for adding that. It's important to note as well. 2 questions I think we can still answer. So can you have an Aneuploid PGT-A result, but the fetus is mosaic and therefore possibly
You could have an Aneuploid PGT result then, but then most clinics won't allow the transfer because they're pretty sure of that result. Yeah, I don't know any clinics that would transfer an Aneuploid PGT embryo.
If it's confirmed it's Aneuploid, they are not transferred. Mosaic is a different story, as we know, of course.
Right.
Okay, thank you so much for the clarification. And probably our final question for today: can multiple trisomy and monosomy in an embryo be an error? They are 6-day embryos, 5AB.
No, you can get embryos with multiple trisomies. That's what you tend to see in older women. Yeah. I mean, I'm assuming that this is a mosaic embryo that carries these multiple trisomies and monosomies. But the more abnormalities you have, the less the chance of success with that mosaic embryo. So if you've got lots of trisomies and lots of monosomies, let's say 5 or 6 chromosomes affected in that way, that embryo doesn't have a good chance of success. You can still use it, but you don't have a good chance of success. But the embryo quality, if I remember correctly, was good. It was a 5AB or something like that. So the embryo quality was good. So that would be an argument for using it. But at the same time, if there are multiple abnormalities, you've got to understand that it's not offering you the best chances of success.
As long as you are aware. Yeah, thank you so much for that, for sharing. As I mentioned, that was our final question for today. So thank you so much for your questions, Dr. Victoria. It's not an easy topic. Thank you so thank you so much for for answering all the questions. You can see thank yous in the chat, I'm sure. So there are plenty of thank yous coming
thank
up
you
your
to
way.
everyone for listening and for your patience and for not very clear answers for some of them. But
Unfortunately.
overall, I hope it was helpful.
Definitely helpful. As we mentioned at the very beginning, it's not a clear answer to those questions. It's not easy to answer. Yeah. So most of the time, it's just how it is. So we need to take it in. That's it, I think. But I do believe it was very useful, interesting. And of course, as always, let me remind everyone that if you have any other questions, follow-ups, or anything that you would like to learn more a bit more about this topic, of course, you can definitely get in touch with Dr. Walker and her team at Institut Marquès. I'm sure they will be happy to answer. And I always say that, you know, all those questions definitely need some more information. The doctors need more information to give you a proper answer as well, because of course we only have bits of the information you provide, but I do think that was really, really useful. Thank you so much, Dr. Walker, and thank you so much, everyone, for your time. It's been great to have you here for sure. We will be back with some more events, and we will be back on Tuesday, so stay tuned. Go ahead to, you can subscribe to our YouTube channel. You will be notified that this event has been uploaded, so I can only encourage you to do that. And of course, I do hope to see you soon here as well, and I'm sure you will have more questions. Thank you so much, Dr. Walker. Lovely to have you. Have a lovely evening, everyone. Have a lovely weekend as well.
Thank you for your time, everyone.
Take care.
Thank you, Caroline. Bye.
Thank you so much. Bye-bye.